name is Amanda Carew, and my project is titled Vaccinia viruses GLV1H100 and GLV1H164 are effective against hepatocellular carcinoma cell lines. Hepatocellular carcinoma, also known as HCC, is the most common liver malignancy worldwide. And the treatment outcomes are poor for this type of cancer because it's diagnosed at a late or inoperable stage. Some common risk factors associated with HCC are cirrhosis, which is scarring of the liver, and this could be from hepatitis B, C, or chronic alcohol usage. Other risk factors include hereditary hemochromatosis, alpha-1 antitrypsin deficiency, smoking, or exposure to alpha toxin. So the main types of treatment for HCC are not that successful. The first type is resection, and it's limited because of the number of donors available. Ablative therapy can only treat the local disease, and systemic therapy has not yet shown to prolong survival. So about 100 years ago, the potential of oncolytic viral therapy was discovered, and patients who had cancer developed the influenza virus and showed short remission to their cancer. So oncolytic viruses are viruses that only infect and kill cancer cells because they're rapidly dividing. And the oncolytic virus that I looked at was the Vaccinia virus. And this virus has a large genome, efficient replication, a good safety profile, and has been effective in several human tumors such as thyroid cancer, pancreatic cancer, and several others. This is basically how an oncolytic virus works. It attaches to the tumor cells, replicates within the tumor cells, the tumors lyse and release viral progeny, the neighboring tumor cells are infected, and we have the anti-tumor effect. So the tumors lyse and they release antigenic tumor cell fragments, which stimulate the anti-tumor immune response. So the two Vaccinia viruses that I looked at were GLV1H100 and GLV1H164. These two viruses are similar in that they both have the code for green fluorescence protein, which is used for in vitro imaging, and the human norepinephrine transporter. And this is important for in vivo imaging with the radio-labeled probe media-idobenzylene guanine. The 164 virus is different and better than the 100 virus because it has the GLAF2 protein, and this protein has never been studied before. It's an anti-VEGF single-chain antibody, so it basically cuts off the blood supply to the tumors and therefore it can't grow. These are the viral constructs, and here you can see that both the 100 and 164 virus have the GFP protein. Both viruses also have the HNET protein, and the GLAF2 protein is only present in the 164 virus. So the purpose of my project was to determine if the two Vaccinia viruses, GLV1H100 and GLV1H164, are an effective way of treating HCC. So first I infected the cells at different concentrations after I cell cultured the cells. And on days 1, 3, and 5 post-infection, I would image for green fluorescence protein. So this looked to see how much virus particles were infecting and killing the cancer cells. Every day post-infection, I did a cytotoxicity assay, and this looked at the percent of survival of the cancer cells. Finally, I did a viral plaque assay after all of this was complete and looked at the viral plaque forming units. Next, I did a Bradford assay and Western blot to look at protein expression, and immunofluorescence staining to also look at protein expression. These are my first results, and this is the HepG2 cell line with both the 100 and 164 viruses. And as you can see in both graphs, that as the days go on post-infection, there is a lower percent of survival of the cancer cells, so the virus is infecting and killing the cancer cells. At the highest concentration of 1, you can see about 80% kill of the cancer cells. This is the PLC5 cell line with both viruses, and you see the same trend. And this is GFP expression. GFP is a surrogate for viral infectivity, so the more green fluorescence you see, more virus particles are infecting and killing the cancer cells. As you can see, as the concentration and time increases, there's more GFP expression, and there's more virus particles infecting and killing the cancer cells. This is the HepG2 cell line with the 164 virus, and you also see that GFP is time and concentration dependent. This is the PLC5 cell line with the 100 virus, and then the 164 virus, and the Hep3B cell line with the 100 virus and the 164 virus. These are the titers for the G2 cell line. And as you can see, as the days go on post-infection, there are more viral plaque-forming units per well, so there are more virus particles infecting and killing the cancer cells. Again, these are titers for the PLC5 cell line with both viruses. This is the Western blot for the Hep3B cell line, and this is just showing that the vaccinia virus is present. So at 24 hours, we see the virus is present and the bands are getting thicker with time, so more virus particles are infecting the cancer cells. This is the Western blot for the HepG2 cell line and the Hep3B cell line. Here you can see that the GLAF2 protein is not present in the 100 virus, but it is present with the 164 virus. Actin was just used as a control, and the HNet was seen in both viruses in the HepG2 cell line. Here again with the Hep3B cell line, you see the GLAF2 protein is not present, but it is present in the 164 virus, and HNet was seen in both. This is the protein expression, and the bright field was just used to show we have healthy cells. The DAPI shows a bright blue fluorescence wherever the cell's nuclei were. GFP shows viral infectivity, and the red fluorescence protein was used to show protein expression. So here in both cell lines with both viruses, HNet is present. However, it is only present in the 164 GLAF2 is only present in the 164 virus. The vaccinia was present in both viruses in both cell lines. So I concluded that both viruses infected and replicated within all three hepatocellular carcinoma cell lines. Both vaccinia virus led to significant cell kill, and the GFP allowed for non-in vitro imaging. The GLB1H100 virus showed robust production of the HNet, while the GLB1H164 virus showed robust production of HNet and GLAF2. So in the future, I would want to do an in vivo study and look at the killing of hepatocellular carcinoma. I would use new mice because they don't have immune systems, and inject them via IV and IT injections. IV is into the vein and IT is into the tumor, and I would want to see which method of delivery is most effective. Also, this virus has a large genome, as I mentioned before, so I would want to find the best combination of genes to create the ultimate vaccinia virus. For instance, we can insert reporter genes, suicide genes, modulatory genes, or anti-angiogenic genes, such as my study. Lastly, the World Health Organization recently created medications to treat vaccinia viruses. So if this virus were to replicate uncontrollably in a patient, we could give them these viruses, these medications, so they would be healthy. As I said earlier, 500,000 people each year are affected by hepatocellular carcinoma, and no treatments are to our perfection. So this was the first study to demonstrate the in vitro killing of HCC with GLB1H100 and GLB1H164. And GLB1H164 holds so much promise for suppressing angiogenesis because of the GLAF2 protein. And this protein is so important because it's never been studied before and holds promise for treating HCC. I would like to thank my mentor, Kelly Mojica, my science research teacher, Mr. Viltakis, and all the members of the Falling Lab at Memorial Sloan Kettering Cancer Center.